So as the next speaker, I would like to introduce Professor Schleicher, who you already heard earlier this morning. And he will talk about clusters in diabetes. And we're very interested to hear what consequences they may have for diagnosis and possible treatment. Please.
Thank you for the introduction. I was asked to introduce very shortly the new clusters introduced by Scandinavian groups, and this initiated a really very intensive discussion in the field. You know, or you still know that I'm a clinical chemist, so I always emphasize also on the laboratory parameters. First, a slide I showed you already is that we have the clinic for the diagnosis of diabetes and laboratory markers. Laboratory markers are hemoglobin A1C and glucose. And the diagnosis diabetes is independent of the type of diabetes, type 1 and type 2. How about type 2 diabetes? Every diabetologist knows that type 2 diabetes is very heterogeneous. For example, this juvenile boy has not diabetes but has clear fatty liver and has a good chance to develop diabetes if there is no intervention. This young lady lost a lot of weight. That's from the internet, all these pictures. And she had type 2 diabetes. After losing weight, she has no type 2 diabetes, so kind of cured diabetes. And the next one, these are Indian colleagues, and they look like to have like 2 diabetes, not really. But they say all of them have type 2 diabetes. So from the phenotype, it's not that easy, not 100%, 80%. You might say you can estimate this may be type 2 diabetes, but you're not sure. They are very different. They look very different. In addition, if you have a high sophisticated technique like MR spectroscopy, you can quantify the different fat compartments in the body. And for example, 2 individuals with the same BMI of 30, they do have very different fat distribution. This, for example, has a lot fat subcutaneously and really nothing in the liver. And just the opposite, this one with the same BMI has a lot of fat in the liver, particularly here, and little fat in the subcutaneously. And our group has defined this is the more metabolically healthy obesity, and this one with liver fat, the more unhealthy obesity. So within the same BMI, it may be positive or negative in terms of the metabolism. To further discriminate between the 2 types, type 1 and type 2 diabetes, and specific ones, except the clinic, we do have the C-peptide and autoantibodies against C-peptide, against beta cell proteins. And we can use that if there's no C-peptide or negative and little and antibody positive, then it's type 2 diabetes. And on the other hand, if the autoantibodies are negative, type 1 diabetes is not excluded. And if the C-peptide is negative or very low, it's still type 1 diabetes. On the other hand, if the antibodies are negative and C-peptide is elevated or normal, then it's type 2 diabetes. So this is our scheme we can use up to now. But on the analysis of about 15,000 newly diagnosed diabetic patients in 1 decade in Scandinavia, Leif Group and his group, they have published last year, and they have followed this analysis and introduced preliminary results in the recent years on diabetic meetings. And what they showed is that we have the classical type 2 amount, which is close to 90%, so that's the mass of the diabetic patients and type 1 and some others. With their new clustering based on, and this is now important, it is based on the age of diagnosis, the BMI, and then all the other parameters are all laboratory parameters. That's why I want to emphasize that based on the value of hemoglobin A1C, the autoantibodies GAT, C-peptide, HOMA B, and HOMA insulin sensitivity. And then with this data, which were clear for were protocoled from all these nearly 15,000 newly diagnosed diabetics, they did cluster analysis with these data because these data were available for all. What is, before we discuss it, what is HOMA? Homeostatic model assessment. This is a mathematical model quantitatively describing the insulin resistance, HOMA-IR, and the beta cell function, HOMA-B or beta. And I just wrote the formula you can look up in the internet, and they are in advance now. Actually, they are derived from academic investigations with clamp techniques, which you cannot do usually in the daily praxis. It is just, as you can see here, a formula with the insulin concentration, that was the first one, and the glucose concentration, this is all fasting, with some factors, and the same with insulin resistance. And you have to watch out on the dimension, and in addition, for C-peptide, there are of course other numbers because there are other concentration. And in the meantime, you can calculate that with the HOMA2 calculator from the University of Oxford. That's in the net, easy accessible. And what did the authors of the Scandinavian study have for late complications? They did have, they could assess the estimated GFR, albuminuria, and for diabetic retinopathy, fundus photographs, and for coronary events and stroke, these were, they had the protocols from international classification of the disease. So that's very basic, very little, but still that is a clear internationally known classification. Now let's come back to this new classification. The cluster first, the first cluster, cluster 1, is actually like conventional clustering type 1 diabetes and late onset diabetes of adult. And this is, like we know, insulin, they have the need for insulin treatment. So not only the clustering, but also the therapy is important. That's not very new. But for type 2 diabetes, which would be pretty much in conventionally, these 4 clusters, they divide it into 4 clusters. Cluster 2, they have high, so very elevated hemoglobin A1C, reduced insulin secretion, but mild insulin resistance. And they have a high risk for diabetic retinopathy. The cluster 3 has adipositas, insulin resistance, and this is important, high risk for diabetic nephropathy. So that's one of the first times that we have a risk estimation for diabetic retinopathy. This has always been known that bad metabolic control, high hemoglobin A1C from the DDC study and others, is a negative prediction for retinopathy, but it was looked for parameters for diabetic nephropathy. Since in the 80s, when I was very often in Copenhagen, and we discussed how can we predict diabetic nephropathy. And there was a lot of genetic parameters tested, and there was no outcome since then, only the microalbuminuria. That still we don't have a better one. And now we do have a cluster which has higher risk for diabetic nephropathy. And the point is, I should add, it's not only academic, this clustering, but the colleagues from Scandinavia, they suggest that the treatment of cluster 2, which is hemoglobin A1C elevated, that they should be treated with insulin. And in their protocols, a lot of these cluster 2 patients were not treated with insulin. And opposite, in cluster 3, they were treated with insulin or other treatments, and they suggest to treat them with metformin, or these patients respond very good to metformin. This is discussed there. Cluster 4, adipose patients with diagnosis at young age, we would suggest that they should be treated very intensely. They say these young patients and very old patients, we don't care about that. That was very surprising for me. So they focus, I'm telling you, they means the Scandinavian paper, focus on the treatment of these 2 groups to prevent diabetic retinopathy and diabetic nephropathy. So we have 2 more talks specific on these 2 diabetic late complications, and you will see what they will tell you. Just to show you one picture of details, this is the only one I show you. The distribution of hemoglobin A1C was elevated in cluster 2. This is the BMI, this is the age, that was rather similar. More important, HOMA B is elevated in cluster 3, and HOMA insulin resistance also in the nephropathy cluster. Again, I show this clustering and what it means, the same picture like before. And as I said before, the colleagues, they strongly suggest to care about cluster 2 and 3 and not about 4 and 5. I'm sure all this clustering is discussed very much in the diabetic centers since the last year. Can these new clusters replicate it? Of course, these are Scandinavian diabetics. They are not globally around, and it was very fast asked if this can be replicated, because there are a lot of cohorts in the world, and very, very fast Chinese and Indian cohorts have been clustered, and they look very similar also in Europe. And one is already published from England, by Dennis and Hattersley, famous diabetologist in England. And they used the ADOPT study, and this is the number of patients and the record study. So if you add them up, nearly 10,000 diabetic people, and they found similar clusters. Just to show you this picture, it looks very similar when using the same statistics, I have to add, just using the same statistic like the Scandinavian cohort, for the Scandinavian cohort, also for the British cohort. And this looks very similar, and also the clustering, the amount of percentage, which is very low, cluster number 1, and this is 2 and 3, so retinopathy and nephropathy and young and older diabetics. This looks very similar, so it seems that this is probably true, at least in European, but also all over the world. But there is new information in this new paper. Particularly, they say what's novel in this paper compared to the Scandinavian one, they say that cluster 1 and 2 and 4 increase in glycemia, so they have prediction what is worsening. And cluster 3, what was the same one, like Scandinavian, and 5, progress to renal disease much faster. So they add more information, and they had more information from the data, so they could draw more information for predicting something. And they had also a lot of information about the treatment of these different patients, and they found the patients benefit from treatment, particularly in cluster 3, and in cluster 5 from sulfonylurea. So there's a difference in treatment, and the follow-up was clear that the prediction can be done and also the kind of treatment. Now I come to the laboratory. Surveys for insulin. This is in Germany, the newest one of this year. And if you look carefully, you have here from the sample A, which is 100, maybe 100 measured in one laboratory, to 800 picomoles per liter, and sample B, that's also 100 to 800. So an 8-fold variation of insulin. What does it say? You realize that the Scandinavian colleagues did not use insulin, but rather C-peptide for their clustering. Why? Because they know that. Although insulin can be measured for a long time with immunoassay, the standardization has not been achieved globally. And you can see the different assays here that depends on the company and the manufacturers. This one measures statistically much lower than the other ones. So the point is advising you not to use insulin as for the clustering. Although insulin is the active hormone that's actually in the body, but C-peptide is only a bystander. But this is the better analytical parameter, because if you look at the distribution, if you use one assay that is very, very close, others measure higher, but the distribution is much smaller. And in the Scandinavian paper, the method section defines very exactly where in the University of Uppsala and all the others, which method in the central laboratory has been used and how you can compare this. Just a short summary of the biomarkers. Like glucose, hemoglobin A1C has been standardized and completely implemented. The discovery was about, let's say, 50 years ago. And the method is immunoassay and HPLC, as we discussed this morning. And standardization has been completed and implemented, and there's a meter, as I said before, and all the manufacturers have to use that for calibration. So this is improving also in the meantime. C-peptide has also discovered about 50 years ago. Immunoassays are available, and in the meantime, after this long time, a reference method has been listed but not yet implemented, and they will do trial in the US in 19, so this year. Insulin discovered nearly 100 years ago. Immunoassays are available since the 50s. There was a Nobel Prize winner, Yellow, who performed the first immunoassays with insulin, Nobel Prize, but we don't have no reference method. We don't have no reference material sent from the WHO, World Health Organization, to be sent out in the world globally to calibrate that assay. There's very little efforts now because it seems very hard to standardize insulin. With the autoantibodies discovered also about 50 years ago, this is also immunoassays, although this is complicated because every of the type 1 diabetic has different autoantibodies, but still here the harmonization is described very nicely by a very active group in Florida and other countries, including Europe, and a reference material is available. So just to show you which laboratory parameters are good standardized and the values can be compared globally, and particularly insulin is a really bad one. Take-home message: type 2 diabetes is very heterogeneous. Biomarkers are only partly standardized worldwide, and insulin needs standardization. Cluster analysis identifies patients at risk for diabetes progression and identifies patients who benefit for specific drugs. So I hope I have made everything as simple as possible, but not simpler, it becomes then wrong. And greetings from Tübingen. Thank you.
So thank you very much for the presentation. Are there questions? Maybe then I'll start with the first question. So these clusters were defined by one analysis at the time of diagnosis mainly. Do you have information about the stability of the clusters? So will a patient over the duration of his disease stay in one cluster, or should there be changes, or can there be changes?
There's no discussion about the stability, but what they do say that the overlap, there's quite a bit of overlap in the parameters. You could see that the variation of the individual clusters is very high. So this is, I think, a start of a discussion, and there will be a refinement after in other, as already started, the British one, and there will be more information, and maybe there will be a different clustering and more information about what happens over time with these clusters. If you are clustered in cluster 2, then you stay in cluster 2 over 10, 20 years, although you are treated, they are diabetics, or they are treated wrong. If they change, I don't know.
Any?
I have also a question, Professor Schleicher. We know that our patients from type 2 diabetes patients die actually from cardiovascular disease. So indirectly, of course, also from nephropathy, but cardiovascular disease, major cardiovascular events and heart failure are the main causes of death. So I wonder, is there a differentiation in terms of cardiovascular outcomes between the clusters?
Yeah. One can look it up in the original paper. I don't have these pictures, all these pictures. There's a lot of information in this, and it is clear that I think the best prediction are for retinopathy, the steepest, cluster 2, dependent on the duration, and cluster 3 for nephropathy, it was clear. And cardiovascular, there's one, but I don't remember the factor that I had. It's not so impressive, but still it's different. But I can't remember which cluster that was.
Any other questions? Okay, then we move forward to the next lecture. Thank you, Professor Schleicher.